Say what's like we can't have policy without so this one dies, and then the family can start receiving some of the networks.
Oh, really?
We're going to expand our economy. Expand it always.
Now, is my developing here?
Production line.
Where there are U.S. companies that are exporting vendors, they're looking at global vendors and they're seeing where there are gaps for use.
Yeah, we're.
Think about what you do.
Sure, I'll try to look
It is 100,000. With HP.
Oh, that's true.
Anyway, so yeah, I'm not going to have
Actually, I'd like to.
No, I will.
Right. Hey, thank you.
All right, yeah. This is the order. Great. Good morning, everyone. We're going to go ahead and get started. Niche.
We're having a private conference back here.
So, all right. Good afternoon, everyone. My name is Daniel Castro. I'm Vice President of the Information Technology and Innovation Foundation. It's not coming through. All right. Good afternoon, everyone. Can you hear me now?
No.
It's still on. We're going to be talking about technical challenges throughout this entire event.
This is the first technical challenge to get people to hear.
All right, can you hear me now? Can you hear me now? Oh, for those of you waiting, we still have some food in the back, I think.
It was really good if you haven't
Really
had
good.
it. Yeah, it really actually was really good.
Yeah, we definitely improved the food here. Coming back.
Good food makes for good policy.
That's in the golden rule, right? Good food makes for good policy.
At least.
Definitely don't want to go sugar.
All right. Does anybody else see the irony here?
There we go. We have okay. We're begin again. Good afternoon, everyone. My name is Daniel Castro. I'm Vice President of the Information Technology and Innovation Foundation. None of my responsibilities have to do with audio in this room. I want to welcome you to this afternoon's event, the future of health data sharing, giving consumers private and portable access to their own medical records. Just before we begin, a few logistics. Today's event is being recorded and webcast, so welcome to those of you who are joining us online. You're welcome to join the conversation via Twitter using the hashtag NHIT Week, National Health IT Week. If you're in the room, we're going to have plenty of time for Q&A at the end, but also if you're watching online, you can submit questions via Twitter. So today's event came about after a series of conversations with Phil Yasnov over here, reflecting on how what kind of developments we've seen over the past 7 years after the HITECH Act. We have this paper that's out in the back called Improving Healthcare, Why a Dose of IT May Be Just What the Doctor Ordered. It was published in 2007. And so you might think that that was a typo and why we have a paper out from 2007 out there. But looking back, in 2007, we really outlined our vision for where we want to see health IT go. The potential for electronic health records, the potential for data sharing in this space, and the type of ecosystem that we thought was necessary to really enable these technologies to develop in ways that were beneficial to healthcare providers, to patients, and to researchers. And the HITECH Act did move us in that direction, right? Most people today have electronic health records, or they're moving in that direction, but we don't have this real vision, and we haven't achieved this full vision of having a patient record that you can easily download, having it on your phone, being able to go to any provider and then instantly having your information. And we're still working on that challenge, but we're not there yet. And so the goal of today's event is really to explore that question. What was the original vision here? What progress have we made? And what steps do we need to take to move forward? So there's a lot here that we want to discuss. I have a fantastic set of panelists here who have all been really deeply involved in these issues since the beginning. So starting to my left, Anish Chopra. Anish is the co-founder and executive vice president of Punch Analytics, which is an incubator for health and education markets. And from 2009 to 2012, he serves as the first U.S. Chief Technology Officer for the U.S. government. His left is David Kindle. David is the Senior Fellow for Health and Fiscal Policy at Third Way. And he's been working on these issues for as long as I've known him. Has deep expertise with a PPI before, Professor Policy Institute. He wrote really many of the policy reports that shaped the conversation we've had. And finally, at the end is Dr. William Yasnov. Bill is president of the nonprofit Health Record Banking Alliance, which has promoted this kind of view of a community repositories of patient-controlled electronic health information. He's also the managing partner of the National Health Information Infrastructure Advisors, which is a consulting firm that helps develop and deploy health IT systems and solutions. He's an adjunct professor of health sciences and informatics at Johns Hopkins University. He's also associate editor of the Journal of Biomedical Informatics. So a lot of great expertise up here. And let's just jump right into it. I asked Bill to kind of kick us off with a little bit of a history lesson on what we were doing 8-9 years ago and what the vision was.
Thank you, and appreciate the opportunity to be here. So, imagine an aircraft maintenance system where planes are repaired in various airports around the country, but the repair records remain exclusively where the work is done. No mechanic has access to the complete repair history of any plane. Crazy, right? Yes, but this is exactly how we manage healthcare records. Wherever you receive care, a record, be it paper or electronic, is left behind. As a result, virtually no Americans today have complete medical records available whenever care is needed. It's no wonder that there are so many costly, painful, and inconvenient duplicate tests and procedures, avoidable medical errors, and preventable adverse events, some even fatal. We can fix this by ensuring the availability of comprehensive electronic patient information when and where needed. There are 5 interrelated challenges that must be overcome to achieve this goal. First, all health records must be electronic. Second, those electronic records must be standardized to allow them to be processed and combined in a meaningful way. Third, comprehensive records must be accessible both for individual care and populations. Fourth, privacy and security must be protected. And fifth, the resultant system must be financially sustainable. Comprehensive electronic patient records are not a new idea. Way back in 1991, an IOM report asserted that, quote, the computer-based patient record is an essential technology for healthcare. In 2001, the National Committee on Vital and Health Statistics, NCVHS, released a report advocating government action to facilitate development of a National Health Information Infrastructure, or NHII, which they defined as a comprehensive knowledge-based system capable of providing information to all who need it to make sound decisions about health. In 2002, in response to this report, I was asked to initiate and lead the NHII effort at HHS. The following year, I organized a national consensus conference of 600 key stakeholders that developed an action agenda to achieve the NHII. In response, the President established the Office of the National Coordinator for Health Information Technology, ONC, in 2004 to facilitate development of, quote, a nationwide interoperable health information technology infrastructure that ensures that appropriate information to guide medical decisions is available at the time and place of care. While the early efforts of ONC were substantially hampered by limited funding, in 2008, the HITECH Act provided substantial financial incentives to physicians and hospitals to use electronic records, or EHRs, that greatly increased their adoption. ONC also used $564 million to fund health information exchanges, or HIEs, to assemble siloed records into a coherent whole for each patient. Unfortunately, ONC pursued an institution-centric architecture for HIEs that left records where they were created and required their real-time retrieval and assembly each time they were needed. This approach proved to be overly complex, error-prone, and financially unsustainable, resulting in widespread failure. Even worse, the substantial improvements in care and reductions in cost we all desire have not emerged because of the consistent lack of comprehensive records. Although we have largely addressed the issue of converting paper records to digital form, we have yet to successfully overcome the problems of standardization, availability of comprehensive records for both individuals and populations, privacy and security, and financial sustainability. Meanwhile, on a parallel but little noticed track, another approach to health information infrastructure was being developed. First described in a 1994 MIT report entitled Guardian Angel, it envisioned collection and storage of the lifetime longitudinal records of each person in one place, a patient-centric rather than an institution-centric approach. Called health record banking, it consists of multiple community-based repositories of patient-controlled electronic health records. This community orientation acknowledges that healthcare itself is local. The vast majority of healthcare in any community is provided in that same community, and helps to facilitate trust in the health record bank organization, which should also be regulated to prevent any improper use of patient information. Privacy is protected by giving control of record access to the patient, so that each person sets their own privacy policy, which is the only approach to privacy that everyone can endorse. This also ensures that records can be collected in the first place, since HIPAA requires providers to give copies of records to patients in electronic form if so requested, although the practical implementation and enforcement of this remains an issue. To address the security concerns about breaches of central databases of records, a new security paradigm called the personal grid, which separately stores and encrypts each patient's record, can be used to prevent the loss of the entire data set from a single unauthorized intrusion. Having each patient's records in one place allows cost-effective searching to provide new benefits, such as finding subjects for clinical trials and generating timely, individualized reminders for care that is needed. New apps that are possible, such as a peace of mind app that immediately notifies loved ones if a family member is undergoing emergency treatment, provide substantial new value that can assure financial sustainability. The transition of healthcare payments from volume-based to value-based is providing new and powerful financial incentives for the availability of comprehensive records. After all, as a provider in a volume-based system, I do not want outside records for patients. It is essential to my economic viability that I repeat tests and imaging procedures that generate revenue to offset the fixed costs of my labs and imaging center. But in a value-based environment, where such additional testing produces no marginal revenue, it is now essential that I have as many prior records as possible, since every test and procedure I can avoid repeating improves my financial bottom line. Furthermore, since I am now rewarded for improving population health, I must have comprehensive records for each patient to have any hope of effectively improving care and reducing costs. Just this week, Aetna recognized this new incentive by announcing that it will be covering much of the cost of Apple Watches for its beneficiaries and encouraging their use with apps it develops to increase healthy behaviors. I believe this is the first in a series of announcements of financial subsidies for consumer technologies to improve health. My expectation is that health record bank accounts will be included in this expansion of coverage to ensure the availability of comprehensive records when and where needed. In summary, while we've addressed the issue of EHR adoption, it is the patient-centric health record banking approach to health information infrastructure that can simultaneously address the problems of making records available, protecting privacy and security, and assuring financial sustainability. Recognizing this, past ONC directors Brailer and Blumenthal have both endorsed such a patient-centric approach this year, and there are over a dozen startups all over the country pursuing variations of this model. I would like to suggest 4 policy initiatives that would help accelerate progress. First, designate and enforce a standard for transmission of information from EHRs. Such a standard was required by the HITECH Act, but has not been established by ONC. The obvious candidate for this is the HL7 Clinical Document Architecture, or CDA. To accommodate continuing health IT progress, the standard should be reviewed for potential updating at least every 2 years. 2, replace Meaningful Use 3 regulations with a requirement for health record bank deposits. The Meaningful Use 3 regulation is many hundreds of pages and has evoked widespread and well-justified concern from providers. The goals of health information infrastructure can be readily accomplished by requiring that each provider deposit the new information from each encounter or the discharge summary from a hospitalization in the patient's health record bank account. This will ensure the availability of information for all subsequent care episodes and not only enable the various use cases contemplated by the current Meaningful Use 3 regulation, but all others as well. 3, designate a health record bank account as a preventive service, making its cost fully reimbursable without copay or deductible by every health insurance plan. This would eliminate any financial obstacle to patients having health record bank accounts. The estimated cost for each account, up to $30 per year, pales in comparison to the potential healthcare savings of $600 per year, about 8% from the availability of comprehensive records. Note that even if the estimated savings are overstated by a factor of 10, $60 a year in savings would still produce a 2-to-1 ROI for the $30 expenditure. 4, provide funding from the CMS Innovation Center for pilot health record banks. The CMS Innovation Center is spending $1 billion a year trying proposed new strategies to reduce costs and improve care for Medicare and Medicaid. Allocating just $50 million of this for 3 to 5 health record bank pilots, which requires no new appropriations, would provide the seed funding needed to jumpstart efforts all over the country. Let me conclude by saying that the sooner we can implement a network of community health record banks, the sooner we will see the benefits of improved care and reduced healthcare costs.
Thanks, Blake. David, you've had the same kind of, I guess, sense of perspective probably now. You read all these papers that Bill cited. You've written some of them. Share with us your perspective and where we've been and what the vision is.
Sure, yeah, it's kind of nice to be take a trip down memory lane. Like you get to a certain age and you actually live in history, and you got to really hold on to the optimism, right? Because it's been a long haul. It's kind of go outline the length of time this has taken. But as we know, it took a whole century to get the ACA passed. So maybe we shouldn't be too impatient here. So yeah, I thought I'd sort of take a look at like what is working, what is not working, and offer sort of even a more practical, sort of very simple way of fixing what's not working. To make sure that as Bill outlined, everyone in this country has access to a lifetime electronic health record that's available 24/7, no matter where you go through your care. So yeah, a lot has happened since I started following this issue back in the 1990s. Let me start with a personal story that kind of, I think, illustrates like the common patient experiences. So about 10 years ago, my older son hurt his wrist playing football. The primary care doctor didn't see anything on the x-ray, but they put his arm in a sling, and they gave me the x-ray to carry to the radiologist's office, just to make sure that there was a double check on it. Well, I got it over there right away. But about a week later, the radiologist's office called and said, well, he's got a hairline fracture. Well, great. Well, what are we supposed to do with that? Well, it's actually too late. You should have put it in the cast right away. Okay, great. Okay, so that was 10 years ago. Let's fast forward 10 years, and my son has another sports injury. This time we go to the ER, and the ER has an electronic health record. And now the primary care doctor is also using that same electronic health record. And there's no more confusion about sharing the information, the responsibility for making sure the test results are acted upon quickly. It worked great. But now my son's off at college, and who knows what kind of EHR system that he might encounter there, should he even care. The patient portal for his current primary care doctor can export that information into either a PDF or a machine-readable document, which is based on the CDA architecture. For the insiders, this is an Epic system that he's on, that the system's on. But we don't know if another healthcare provider would be interested in and able to use that information. And so it's just not clear if my son's going to have a lifetime digital health record. So what have we accomplished over the last 10 years? One way to think of this question is, are we on the cusp of a massive data flow that unleashes the power of network computing in healthcare just like the internet did in the 1990s? Or have we simply created silos of data that can't go anywhere, that's only marginally better because it's electronic instead of paper records? So is it a optimistic scenario or pessimistic scenario? It kind of depends on where you sit. Because as Bill alluded to, nearly all hospitals today have an electronic health record. 83% of physicians are using an EHR, but no one in this country has a lifetime health record that they can use 24/7 anywhere they go. And the National Partnership for Women and Families had a great campaign called Get My Data campaign. And I don't right. I don't want to. You might be talking about that.
No, you're fine. Keep going.
Just briefly.
Keep going.
It was a fantastic investigation of whether patients can actually get their data. They actually ask people to go out and look for it. They encountered all sorts of problems, like oh, we can't give that to you, it's not your, that's our data, not your data. And sometimes the costs for just outrageous. You're getting people on CD-ROM, well, that's helpful, I guess, maybe a little bit. But there was all these obstacles that patients encountered in getting their data. And then you have the problem of what if you actually got your data from your doctor's office, what can you do with it? And so the Partnership for Women and Families on their getmyhealthcare.org website has a great list of the very health record banks that Bill was just talking about. It's a great list, you all should check it out. One of them I looked at works like MITS, that financial package thing where you can put all your financial accounts into one account and then automatically updates that information from all the different sources. In this case, what the Health Record Bank is doing essentially is updating all those patient portals that are available to consumers now from their providers who have their health records on electronic systems. So that sounds pretty good. What's not working now? Well, it's with healthcare, it's not just like bringing your data to you. I mean, that's helpful, but that's not what most people want to do. Most people don't even want to bother with this, right? They just want to have the doctors have a complete picture of themselves so that they can get the best care possible. So we need a system that gets data to people and then back to their providers. And so I think what we're missing here is kind of like a nurturing of the demand for exchanging information. And as Bill alluded to, it's beginning to happen with value-based purchasing and value-based healthcare. Those incentives maybe are not as strong as we might think. They're still kind of coming online. But there are lots of organizations out there that are really kind of beginning to feel the need to have that complete picture of a patient's record. So this is my suggestion for what we can do in a very practical step. Medicare should support those providers and plans who want to do this for consumers and get all that information together in one place. They can build it into existing awards for high-quality care through the new LIPS program, the new macro payment reforms under Medicare. They can do it through the quality bonuses for Medicare Advantage plans. In other words, we could fairly easily, with just a few, kind of relatively minor regulatory measures, and create the right incentive for providers to actually do this, because I think the time is right for them to actually consider that. So it is a question of half empty, half full. I'm always a half full kind of guy, but I do think that we with a little bit of effort, a little bit more consolidation of thinking about this as you put this together, and hopefully it will help, sort of make sure that we can move in this direction in a way that will be aggressive and produce huge benefits.
Thank you.
Yeah, I'm definitely an optimist, and I can't wait to maybe share some perspective and then go from there. A little shout out to Bill. Bill has been my neighbor in Arlington, and he bent my ear a decade ago or so around this vision for this, and I kind of listened, and I thought this made some sense, but a lot of policy levers were in play, and I'm very proud to say that Bill had it right. We need a patient-centered model. And we're getting closer and closer, and I think we're a lot closer than perhaps is even well understood. So maybe I'll share some context about where we are. First, a bit about how we got here, and then where I think there may be some gaps. But optimist, David, optimist. Let me express why. Number one, we're literally 6 months away from the biggest technological upgrade in our healthcare infrastructure, and that is certifying the electronic health record systems to provide patients the ability to connect an application of their choice to their health data, and for the nerds in the room who follow regulatory matters, without the need for a business associate agreement or other sort of impediments. Basically, I should be able to, as the president said, take my health data to the applications and services that can help me understand them. That may be an extension of my provider, it may be someone altogether separate, it may be Watson in the sky. Whatever the answer is, the technological capacity for a consumer to connect their data to an app of their choice will be certified over the next 3 to 6 months. And as early as this week, Epic, Cerner, and Allscripts posted on an open listserv that they intend to pursue an open API, not a proprietary API, to enable this functionality. Now, we won't know anyone else's opinions until it's officially certified, but the news looks really promising, and not victory lap today, but certainly a lot of enthusiasm and good news about capacity coming online. Now, a little bit of context. I'll make a friendly amendment to Bill's history about our investment framework, because he gave you the mathematical accuracy about the dollars spent on HIE and some of those other things. But it would be remiss on my end to not say that back in 2010, under David Blumenthal's leadership, we had actually defined health information exchange as a portfolio. Not one better than the other, but a compilation of features that in any circumstance might be deployed to achieve the goal. And Bill's right, a big chunk of money went to what we would consider the traditional health information exchanges that were effectively middlemen that were stood up with public-private charter governance in each of the regions and states in which they were operating, with a heavy dose of Recovery Act funding to get them a chance to lift off the ground and achieve some level of sustainability. However, that model, while funded, to this day has never been regulated. In other words, when it came time to finalize a rule making this functionality the bedrock of a healthcare delivery system, and my brother in arms, Farzad Mustashari, has spoken about this quite eloquently. He proposed the governance rule for health information exchange, only to have 98% opposition in comment period to then have the administration pull the rule. Having said that, the other two parts of the portfolio did make it into regulation, and while they were not subsidized to the tune that Bill outlined the HIEs were, they are now encapsulated in regulation. What are they? One, we thought, well, gee, if you wanted to push your information from one place to the other, there's like a really simple way of doing that in an electronic format. We kind of use it every day. It's called email. And gee, if we could simply wrap an email standard with some security features that allowed us to authenticate the sender, authenticate the receiver, and encrypt the message in between, the marginal cost of sending said secure email, with the attachment being your health information, could be pennies. And thanks to Aaron's leadership and others, it's pennies, right? So we have Direct. Direct is a technical standard that is now ubiquitous. It was mandated in the second stage of meaningful use, and every healthcare delivery system, the 90+% that are on stage 2 certified hospitals, and the doctors are coming soon, is capable of doing this functionality. Now, has it been fully implemented in a smart way? No, we could talk about the failures of implementation. That's not today's discussion, but it exists. The other model is exactly what Bill outlined. Patient-centered, what we referred to as consumer-mediated exchange. And the idea was, we already have a governance rule for information exchange. David Kendall, that governance rule is HIPAA. The governance rule is, if you have my data as a HIPAA-covered entity, I'm entitled to the individual right of access. We already have the rule. We just didn't connect the dots between that rule and certification standards to close that loop. So now we have the benefits of a rule, a governance framework, and now, thanks to the ONC's leadership, a technical approach that would allow a consumer to digitally connect their data to an application of their choice. And that was called the application access requirements under the third stage of meaningful use. I'll come back to what that is and what it is not in a moment, but let me just get to on where we are. So again, the upgrade. Every vendor today that wishes to sell in the marketplace for MACRA, MIPS, and beyond must certify that they offer patients this capacity CMS did not require a particular standard. It left it as a functional, aspirational one. That is, if you wanted to share my medications data to an application, all you have to do is document how an application can go get it, and then it'll work. Every vendor has to disclose exactly the recipe on how to get the medications list if the patient said authorized the connection. It'd be better if that medications list was brought back in a common format. And so the industry wasn't obligated to, but it formed kind of a self-governance model without any kind of overhead or organizational structure. A number of the vendors said, geez, we're all going to have to create this capacity. Why don't we do it together? Share the learning, share the code, not a lot of competition in how well you can express the meds list to a patient-facing app. So Epic, Cerner, Athena, McKesson, Allscripts, a bunch of others, said let's all pool some private resources. And a group of folks said let's do this, but do it on top of an existing standards program, the HL7 model. And in this case, the HL7 FHIR model, which allows a machine to use modern internet communications methods to pull out the health information. So your vision of using the internet for healthcare is coming. This is what Mitch Kapor called the health internet back in 2009, and I believe it's coming to life with these regulations. The community said, here's what we want. We want to do the meaningful use requirements, which is what's called the patient summary file, the common clinical data set. We want to be able to map each of those, not as a big document, okay? With all due respect, Bill, I love the CCDA, but that's a big document. Internet isn't all good about document sharing standards on the internet, but really data sharing standards is kind of where we are. So you take the same stuff that's in the CCDA, labs, meds, problem lists, vaccinations, etc., and let's rip it apart into component segments so that if I just want your blood pressure, I don't want to read a 1,092-page CCDA, which one CIO shared was literally a patient when hit print, turned out to be 1,092-page CCDA. That's not the easiest thing to ship around the internet. If I just wanted the blood pressure reading, I could go grab the blood pressure reading, and it's history. So the Argonaut project, open source implementation guide for any vendor to use, freely available, open testing, any app developer that wants to play can do so. All of this is available, and as I mentioned, at least on the community listserv, Epic, Allscripts, Cerner, to date, I'm sure others will follow, stated their intention to certify off of this Argonaut project implementation guide, which is a great step in having an open model. Now, resources are obviously an important question. Both David and Bill alluded to the fact that maybe we need more resources. I'm going to make a slightly contrarian view. The funding's there. The table scraps on information-specific funding may have dried up. That is to say, meaningful use dollars have been spent. Maybe there could be a few more crumbs added to the table. But we're literally talking about transforming the trillion-dollar healthcare delivery system. And the big money is how do we get patients that are hypertensive to keep their blood pressure under control. If we reward that, it will naturally lead to a financial incentive to go get the blood pressure reading where it was last taken. And oh, by the way, if you're one of the millions of Americans who's gone to a Walmart to have a blood pressure reading stored in their kiosk for free, that's an important place to go access this information too. And last I checked, they're not meaningful users and they're not subject to these rules. But it may very well be in the best interests of the organizations who are caring for patients in a holistic way to say, you know what, it'd be great if I could connect to your Walmart blood pressure reading so that I can help make sure if you're hypertensive and you had a bad reading, we can do something about it, enroll you in a program, et cetera, et cetera. And the economics of that, I hope, will work through market forces and hopefully keep pressure so that these costs come down. So that's where we are. The challenge now is where are we heading? It's all academic in theory to say that these standards are there and people are certifying. When's the first production level taste of this? Well, I would argue President Obama's given us the roadmap. He wants 1 million Americans to participate in precision medicine. And an important statement by the president is that you should have the authority to directly enroll without having your doctor do it for you. This will help people in disadvantaged communities, inaccessible communities who haven't historically been capable of accessing these things to do so. So, I believe a very clear and promising place to have this experiment tested is whether or not patients who wish to participate in Sync for Science can do so using the exact same schematic that Bill outlined, rather than deposit it to my bank. In this case, the bank would be some research cohort that's in aligned with the precision medicine, but it's the model that could feed a bank over time or anything else. So that's happening. And all the big vendors have pledged to support that effort in as much as limited burden as possible. Second, I believe that all and every one of the big, now we're getting into the excitement about, what are we going to get? Let's assume I get in. There's a question. Is the HIPAA governance rule satisfied if all you get is the common clinical data set? Well, the answer is actually no. There's something in HIPAA called the designated record set. David Kendall, have we defined as a country what the designated record set is? It's like this amorphous unicorn. I don't know what it is. It depends on the institution and how they interpret it. But we have a regulation that's called Common Clinical Data Set, and then we have this amorphous idea of designated record set. Clearly, someone has to close that gap. So we got to do that. Number two, it's important for the patient to be able to access this data, but that patient may very well have a doctor who's incentivized under the new payment program, MACRA, to do as I said, which is the blood pressure reading from Walmart shared back with their primary care doctor. There needs to be a mechanism by which that patient can delegate their primary care doctor to gain access to their account. So we've got a pretty good model to get the patient to get their data. How do we allow the patient to delegate a caregiver, a primary care doctor, whatever, someone that can access that information? And last but not least, we have a global problem, not a healthcare only problem. On the internet, I want to connect this app to my record, my health records. How does the health record holding entity know that it was me asking this app to connect? We have a national challenge around digital identity. And so no unique problem for healthcare, just that we have all these problems. And this is yet one more use case to move the ball forward on how do we go to make sure the consumer is the consumer who's requesting this data. If we do those three things, I believe the economics will flourish around this model, the regulations will be tweaked, and the apps will flow that will help parents and families interpret their information to get the most out of it. And yes, we have some of these issues to tackle, and some of them may require legislation, but the movement is clearly in the right direction. I went longer than 7, I apologize.
That's great. No, that was great. So I have some questions here, but first I want to kind of get some reactions. We've heard, I think, a few different perspectives. And what's interesting to me is, I think this somewhat reflects the dialogue we've been having for a long time, which is that there's often very good agreement on what the vision is. And the vision changes slightly, so now, we're not talking about just data everywhere, now we're talking about it on our Apple Watch, right? So it fits with the technology. But there's still this tension between both, how much should the private sector lead versus the government lead? And how much should this organizing process be bottom-up, community-driven versus a more top-down approach, and top-down naming government, naming industry, right? And so you have these two different, you can think of it as this kind of dimensional space, and different people are coming in on different places. So we agree where we want to go, but we're all pulling in different directions for how to get there. And I think that's part of the reason we don't always make progress in this space. So not that we can just resolve that, but that is a tension. And how do you see that tension playing out in this debate about where we go next? I'll just throw it out anyway.
So let me say I certainly agree with Anish that we're moving in the right direction. And I would also strongly agree that we're going to get there. And the policy things that I suggested, I think, would accelerate it, but we're going to get there. And the reason we're going to get there is because we need to solve this problem, and this model works. And I think people are realizing that. So I think it would be better to get there sooner, but there are various ways we can move forward. I want to introduce another idea into the discussion, which is the idea of completeness. So and I want to talk about this in three different contexts. To me, in order to have a successful system that provides comprehensive records, you need to, and I'm going to talk about a community, but we can extend it any way you want. You need to have three things. First, for most of the people in that community, the overwhelming majority, you need to have, so that's one area you have to be complete. You need to get most of the people in the community. And for each of them, you have to have mostly complete records. And this concept is very, very important. In healthcare, if you have 50% of someone's records, you don't have any value. So for example, if there were a system today where any authorized provider could get half of anyone's medication list, no one would use that because that has no value. So you need to have, in my experience, 85-90% complete information, and people need to know it's complete before anyone is willing to rely on it or use the system. So the information for each patient has to be complete, or relatively complete, and people have to understand and believe it's complete. You need to have this high number of people in the community, high percentage penetration in the community, because if you expect the providers to change their office procedures to access this information, it can't be just 10% of the population. That creates a process exception in the physician's office. And if you've ever seen physicians' offices, the last thing they want, need, or are willing to do is to have some kind of process exception. So you need to have the physicians, before they go for this information, they need to know that in most cases it's going to be there. And finally, you need to have most of the physicians in the community actually accessing the information, because if not, then you don't really get the value. So my consistent focus on communities is that within a community where you have a population of people who are getting the vast majority of their care from a limited number of providers, you can create these relatively complete records. You can get to a high penetration of people, and you can get to a high penetration of providers, and it's then where you really get the value. So I want to introduce that characteristic into the discussion.
Well, can I make I'm going to be a very friendly rebuttal, because I love Bill. Let me make a friendly rebuttal. Medicare in 2011 launched the ACO program, Accountable Care Organization. And what it said was, today we're at roughly 1 out of every 4 Medicare fee-for-service beneficiary is in one of these programs. Here's the deal. You're a doctor, you're a hospital, you can come together and form this group, and here's the way it works. Medicare will provide for you the longitudinal claims history for just those patients that are deemed to be your responsibility. The patient will have the right to opt out. We had a privacy feature that said the patient can opt out, and less than 3% of the country have opted out. So by and large, this information is flowing. That doctor or hospital has to now, you call it a process exception, they call it an opportunity to get into value-based care. They're developing care management processes, care coordination processes. They're using just the claims history level, data, no clinical, except for their own, and they're able to develop a great deal of programs and initiatives to find the patients that are high risk, to engage them in a more clever way, and to be even more precise about it. On November 15th, they can run a list, show me every hypertensive patient that has had a physician visit, not me, before the end of the year. Let me call that provider and say, hey, when you got their blood pressure, was it in control? Because I had them in my model as hypertension but controlled. When they saw you, was it still controlled? They manually do that today, Bill, but they get it. And then they use that to say, okay, we've got 6 weeks, let's call those patients and bring them in for another checkup so we can do what we can to make sure their blood pressure is controlled, because we have to report on how many patients that are hypertensive have had their blood pressure controlled. So it's a small percentage of their population, what percentage of their patients are in a Medicare ACO, call it 10%, your number. They built completely new workflows around it to use that information to do something interesting, and they're engaging patients in some form or fashion to help basically move this. Now, that's very analog because they're having to manually call and fill in the gaps, but you can see your vision of a health record bank very clearly something that an organization like this wishing to sponsor so that it can start doesn't have to do this stuff manually. Back to your point about the philosophical issue about where do we go on this tension, I think we found our Goldilocks moment. And the reason we found it is, number one, history, number two, energy as a case model, and three, what's happened already. History. I learned when I was CTO that we had misunderstood the role of government in private sector standards activities. Because of President Clinton, who we worship at the altar, he had clarified that the government's not going to be in the business of setting standards. That's American policy. What was not clear was, what do you do in a case like healthcare where you want a standard to give patients electronic access to their data, but no said standard exists? What's the government to do when no standards exist? We've had a lot of history in healthcare trying to harmonize standards, but if none of the standards being harmonized can provide a machine-readable copy to the patient or its designated app, what good is harmonization? Well, Cass Sunstein and I, when we were in the administration, said, well, let's clarify this thing. Under issues of national importance, where no standards exist, we can widen the aperture. So, borrowing a page from the Internet Engineering Task Force, which is not a standards development organization, as you know, we can work with consortia who wish to get new standards off the ground, and absent anything else, can reference them in regulation and so forth and so on. Aha, we have a path. It's the path of nudging industry to come up with these rough standards and then to scale them up through techniques that are available, which is, by the way, the exact playbook we ran when I was CTO. Healthcare was a priority, but so was education and energy. Literally, in the Recovery Act, $30 billion for health records, $10 billion for smart meters. We don't talk about that in these forums because they're not the same thing. Well, what happened in energy? Daniel? In energy, the US government did not have regulatory authority because we don't. States regulate utilities, not the feds. Aha! But we funded all these smart meters. We wanted them to agree to interoperability standards. But what's the interoperability standard for how a consumer gets real-time access to their smart meter data? David Kendall? It did not exist. So I picked up the phone. By the way, I used to give speeches all over the whatever. Oh, we got to have a standard. We called it green button. We wanted to have all these ideas. Like we did blue button for healthcare, green button for energy, my data button for education. And you're kind of waiting for someone to raise their hand and say, sign me up, I'm in. And boy, I got a lot of nice, oh, we love this idea, sounds so much fun, we'll do some pilot, blah, 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 blah. Nothing. Absolutely zero, zilch uptake. So I just cold called a woman named Karen Austin, the CIO of Pacific Gas and Electric. And I said, Karen, she came out of retail. I said, Karen, is there any chance you believe that your consumer should get access to the smart meter data that you've deployed? Absolutely. Do you have a method to do that? No, we don't. Would you be open to putting said method in? I think that's a wonderful idea. Would you do it in an open way that your colleagues in the utility sector could collaborate on? Sounds like a brilliant idea. Well, why don't we organize this? You know what, Ish? Come to my office in a few weeks. I'm going to bring my colleagues in California, the other utilities, and we're going to have a conversation. We had a conversation where basically 5 CIOs, CTOs, and 50 lawyers from general counsel talk about how awful this is and regulatory and how dare you and freaking out. And we reached a consensus that in 90 days we're going to make this happen. And they had the choice on what technical architecture to pursue. There was no federal government dictate, Moses tablets, blah, blah, blah. And they all worked off of an industry standard and made it better. 90 days later they launched. And today, 60 million Americans get their energy from a company that's voluntarily pledged to deliver consumer data via this common open standard. And when you go to the webpage for the patients who want to connect, consumers want to connect apps, they say, we use the Green Button Connect data standard, which is conformance testable, which has all kinds of specifications, and there's no intellectual property constraint, no fees, no information blocking, nothing. Okay, and no vendor was like dictating how this is supposed to work. I don't even know the names of the vendors, SAP, O-Power, right, that were involved. They didn't do anything to complain, limit, constrain, issue, because the CIOs led this consortium and made it happen. That's the architecture of the Argonaut program. Argonaut is an open model for the industry to self-organize and get to the answer faster. So we don't have to wait for the next treaty from the government that says thou have to do this. We've got the air cover. You got to have an API. That's good enough. Now we can organize and say, what should it do? How should it handle identity? How do we expand the data set? How do we go this? How do we go that? And we can move. And I intend that we move as fast as we can because the energy community showed us the way. And that's the role of government. Nudge, convene, inspire to action, and scale through regs as industry starts to hit rough consensus running code. How about that, Daniel? That's your answer.
That's great, that's great.
I gotta get into this. So, if y'all haven't read it, there's this great book on the, where the barcodes came from. Like, barcodes, I mean, they came out of nowhere. It was actually 20 years of fighting between the retailers and the manufacturers over the system. And then finally, it was a deal struck by the retailers who went to the FTC and said, can we get this done without getting into trouble with antitrust? And the FTC, they didn't do anything. They just said, okay, we look the other way. So the lawyers weren't getting upset, and then the deal was struck. So that was even a more smaller nudge, but that was smart government, right? So I think what you're seeing here is like 90% agreement. And I think but to answer your point, and just to create a little tension, the use case that you just kind of went through with finding that hypertensive information would be so much easier and much more efficient if we had broader use of a patient account that a provider authorized or can in fact signed up the patient for, which was what you're talking about. But to scale that, I can totally agree that the government is not the right place for mandating standards on the high, which no one wants to adopt. It doesn't. That kind of works, but it's very ineffective. But what we can do in the government is to provide that clear signal to the market, in this case providers, that this is what if you do this, you're golden with many meaningful use.
Yeah, but I think that the reg kind of says that. I mean, what you'd be saying is being clear about what a class of app called the record bank app gets special treatment, and that right now there's nothing prohibiting a community from organizing that common bank and having that be the thing that patients are encouraged to adopt. And I do believe maybe there is some opportunity for seed funding to test those experiments and so forth. There's no disagreement about let's experiment, but it sits architecturally on top of the current foundation. It need not deviate.
Well, I think part of the question there, though, from what I heard from Bill, is that, do we just say the patient has a right to the data in abstract form, or do they have a right to have their data managed in a responsible way by some entity? And that's getting to the idea of, having it be part of preventative care, right? So there is some question there about, how much are patients owed? Are they owed just the data, or are they owed responsible management of the data, certain APIs, guidance over how it's shared so they don't maybe have to make those decisions themselves, which was a big part of our original paper where we said, look, it's not enough to just give patients the ability to share their data for research. What you really want to do is create a whole ecosystem where the patient is incentivized to be sharing it. So if I give my data to a health record data bank, and I trust that data bank, and they come to me and say, look, there's these great programs that we can put your data into for this new research, you don't have to worry about it. I trust the data bank, all my data goes out automatically. We don't have to go and ask every single American, will you voluntarily sign up?
So a friendly reaction quickly, I know Bill has a comment. What happens today if you're an app developer and you register on HealthKit versus a regular app store? No, you're obligated under the rules of HealthKit to sign on to the ONC model privacy notice. A consumer who uses an app that connects to HealthKit comes with a layer of protection beyond the generic app. What you're arguing for, and I think perfectly appropriate, is we want a fiduciary clause that says, do no harm, I'm going to act in your best interests. And I might argue in today's era, I might want to add a security rule that says I'm going to encrypt your data, I'm going to do good hygiene, I'm going to make sure it's protected. So now let's imagine, Daniel, that you have a new health kit or Samsung or Android or whatever, and it says, okay, the only apps that we can connect to are those that meet this really high bar. Now you've got a trusted center. Is that a record bank? Sure. Could that get reimbursed or have some model? No reason why it can't. And it may very well be that ACO networks might prefer having something like that they can trust, so that doctors can determine which apps they want to put into it. Not everyone, because some can be shady and they do bad things. So, but what in the current regulatory framework prohibits that?
No, nothing prohibits it. The question, going back, you mentioned, Cass Sunstein, are we creating the choice architecture that is not only incentivizing companies to move in this direction, but also consumers? Because, there is this big contrast with, the White House Consumer Privacy Bill of Rights, which is more about data minimization and control and the idea of opting in. And, that's a big
Slightly
tension.
different.
It is different, but when we're talking about data, we have to still make these big choices about,
Yes.
Are we going to be opting in? That is, are we going to make everyone take a proactive step before their data can be used in useful ways? Or are we going to have opt out, where we allow...
And it's going to be yes and. What did I just say the Medicare ACO rule is? Opt in or opt out? It's opt out.
Yeah.
So what we're saying is we have an architecture in healthcare where if there already is a trusted relationship, when you sign up for Kaiser, as a function of you signing up for Kaiser, you've opted in for massive amounts of sharing because they vertically integrate the entire network. When you sign up for a PPO product that lets you go anywhere, which is what Medicare is, you're not expecting A and B to talk to each other because you paid for a product that lets you go to each separately. So it's a different structure. And so, you're locked in the Kaiser vertical model, completely freedom in this model, with a gray area of the ACO contract, which says you have the right to opt out. And I think we're going to see continued debate about which parts of healthcare under what circumstances should be opt in, which ones should be opt out, what level of consumer protections are expected. But these are things that we can engage on. So like right now, consumers are given the choice to spend $8 a month to enroll in a program called chronic care management, where their doctor says to them, if you pay me $8 a month, I'm going to organize your health records, I'm going to study them at least 30 minutes a month, and I'm going to be available to you as needed. That exists today, and doctors get paid, $42 a month. How much of that $42 might the physician pay to establish the equivalent of a health record bank to organize the information so that they can understand it as they provide that service? I don't know what it's worth. Is it worth $10, $5, $100? Your math of $60 a head or whatever, $5 a month. Is that appropriate? Would a doctor pay $5 a month to be able to do that? The beauty right now is the rules are there, the reimbursement's there, and now we can see. I would love a group of doctors that love the engaging chronic care management to sit down with Bill and say, how can we construct a model like this so we can deliver this value proposition and consumers feel confident when they pay $8 a month, it's coming with all these goodies. And that may be the opportunity.
Something else, right?
And so I don't know, but the economics are here. It's just got to be organized. And the question is the organizing framework for this ONC? Is the organizing framework for this CMS? Or is the organizing a framework for this bottom-up, individual groups of doctors and hospitals organizing in value-based care trying to sort this thing out? We'll see.
Bill, I want you to respond. I just want to broaden the question real quick. And that's that, so David Blumenthal had this op-ed in the Wall Street Journal recently, and he just identified that the problems here are both economic and cultural.
Yes.
So I just want to put that on the table before you respond.
So let me say I agree about your vision of what the government should be doing. I think the best argument for not having the government lead this kind of activity is essentially the result of ONC's work over the last 12 years. That some progress has been made, but we haven't really solved the problem. I think providing, in my view, actually what I wrote an op-ed in 2008 at the beginning of the first Obama administration suggesting the following plan, that at ONC, instead of trying to have rules and give out money and so on and so forth, basically to do one and only one thing, which is the following, to provide $1 per member per month to any healthcare organization that can show that it regularly can provide comprehensive electronic patient records when and where needed. And so then you only need two people in ONC. You need the director and an administrative assistant. The administrative assistant makes appointments for the director for people representing healthcare organizations who come in and make the case that they are satisfying this requirement. And if they satisfy it, then they get funded. And if they don't, the ONC director sends them away. And I call this pay for results. And I think it's a very effective way for the government to get the results it needs. And this has also been used in the private sector with the X Prize awards and so on, where you essentially incentivize the result you want. So I'm all in favor of that. And so we really don't disagree on that. I did want to comment on the ACOs, which is a wonderful first step. But let me say this. I think the difference between what we're saying is, you're talking about examples of how we're moving in this direction. And what I'm talking about is where we need to go to.
Sure.
The result. And my argument would be that what we're doing with ACOs and all the other experiments we're doing is we're setting up multiple phone companies in the same community. This is what happened when telephones were new. And I'm not old enough to remember that, but I've studied the history. And when the telephone was new, every community had one or more mom and pop telephone companies, and they all strung up wires, and they all had different standards, and they didn't talk to each other. And so what happened was Theodore Vail from AT&T essentially went to Congress and said, look, this is a mess. We need everybody to be able to talk to everybody else. We can fix this problem. We'll set the standards, but then, of course, we become a monopoly, so please regulate us. And Congress said, okay, you be the monopoly, we'll regulate you, please fix this problem. Now, I'm not suggesting that in the health IT domain, but the fact is that we have to specify the results we need in sufficient detail so that we can build this infrastructure. And as I'm suggesting, I think if we had some pilot communities, I mean, again, CMMI's mission is to find payment mechanisms that improve care and reduce costs. And they're spending $1 billion a year, allocating a small part of that to experimenting in communities where you essentially say, we're going to create the complete solution because we want to see if it works the way we think it does, and we want to know how well it works. That seems to me to be a good role of government. So again, I don't think we're really disagreeing, and I think all the work on ACOs is wonderful.
Well, but so the idea of petitioning CMMI to pursue an idea like this is a wonderful one, by the way. And I can't speak for their priority set and where that ranks, and I certainly love the spirit of it. But one clarification though is when these islands in these communities, let's pick a community like the greater DC market in our backyard. We probably have 8 or so functioning value-based clinically integrated networks, some of whom are Medicare ACOs or private payer ACOs or what have you. And you're in one degree correct in that each of them is developing their own infrastructure for how they're doing their work. But, and this is a big but, thanks to the work of ONC, I'm actually more optimistic about the last decade, but thanks to it, we now have a common technical standard for how an application of a patient's choice can plug in to that internal network, pull out their relative information, so that if I was a patient at MedStar and I want to switch to a Privia Health network, or I want to join Aledade, or all my friends that are running these wonderful companies want to do, I should be able to do that with ease. And all I'm saying is, if they're using certified electronic health records, which they're obligated to do, in 6 months, they're going to be upgraded to the capability where I can connect any app to do that. Now, maybe who will emerge? Maybe Microsoft, Google, Apple re-emerge as consumer-centric repositories. Maybe. Maybe doctors I trust start introducing digital tools to say, hey, I'm Dr. Jones. Here's my Dr. Jones data collector. Could you please connect this to all the places that you have it? Mint.com style. Or will there be, care networks or other other entities that are going to say, look, I'm an interpreter for you. Bring me your, I'm the equivalent of the Genius Bar at Apple. Bring me your stuff and I'll give you advice. We make bad decisions on what Part D plans to buy. You make bad decisions on the qualified health plan marketplace. You basically make bad decisions on almost every healthcare system. And when science can compute the objective right answer. Person with your son that has this condition should see Dr. X to be absolutely ready to get back on the game field without the least burden and the highest, recovery rate. Great. Thank you, Siri, for giving me that advice, or Watson, or whomever. And so I'm excited about those prospects. And I guess I'm concluding by saying it's not government didn't do its job and let's now try a whole new way. I'm saying it actually has found the Goldilocks model when we tried to force certain document standards, then maybe that may have stifled or limited. We do nothing and it's chaos. And so we found Goldilocks, which is, look, we want machines to be able to access information functionally, go forth, and when there is maturity, say we get some tipping point where the bulk of the folks are using the Argonaut Fire spec because it's the most obvious way to go, ONC has every right to say, we're just going to name that in the reg, if they chose. So there's some clarity so that the long tail come on board in the same way. But I feel like we're on that road. David? You like that road or not like that road?
I'm all for so I think that's the way to go, and then we just need to be prepared to scale it up. But I think that we can do that the top down as well as the bottom up, more in sequence. So we spent the last year in Congress debating interoperability, which wasn't even the right debate to have. And so the leadership first of all, it's just a huge indicator. If we had this panel before the health committee, they wouldn't have even bothered.
Well, but what could they do? But
what could they do? Right.
Well,
so we want to give them something to do, maybe.
Yes.
And so the things you
No. But what's missing? What's missing right now? No. Let's say everybody's a good person and they're doing good things. So let's say Congress are good people doing good things. Right now, my API only works for the common data set, not for the HIPAA designated record set. Congress could say, I want APIs for the designated record set.
I'm for that.
Maybe.
And also I would say, if we can reduce some of the burden of meaningful use for docs, you'd be very popular.
Well, one of the big burdens,
so but
a lot of the burden is that you got to get data to show the quality outcomes, so you have to know my hypertensive patient that has a blood pressure reading, under the rule, has to get the last reading before the end of the year, which is often not in my practice. So then I'm annoyed because now I have to pick up the phone. What was the reading? Do you know it? That's annoying.
Well, I want to open it up for audience questions, but I want to have one last question to the audience before we do that. And that's on this issue of privacy and security, which we've talked about. Is that different than these functional requirements? Is there more or less of a role for government to specify? And let's focus on security because we talk a little bit more about privacy. On the security side, which constantly comes up, is there more, less government role, or are we at the Goldilocks moment where it's just right?
Each of those things have their own Goldilocks communities. So on cybersecurity, NIST has established a framework to make it better. So they just released updates on how to be smarter about passwords. You tell me if any patient portal is at the leading edge of portal security identity resolution activity. So we don't need to do anything different. We just need to say, hey folks, point your feet over here. Look at what the NIST cybersecurity framework is doing. Here's how you do things to salt and hash the passwords that you store, and here's how you establish a mechanism for multi-factor authentication and all that. They've been publishing wonderful documents, and I think the entire economy is thankful that NIST is doing this kind of thing in an open, collaborative way. And private.
Can I ask on that? I mean, so we've had a number of major health data record
For sure.
breaches. Long background in cybersecurity. most of these things, consulting your house, I mean, these are things that we knew.
From the 70s.
Yeah, so I mean, it's not a question of, well, just put a document out, so now we just need to tell them to go there, right?
Yeah.
I mean,
No, but now they're
something else
feeling
that's not
financial
working.
pressure. No, for sure. Look, I would say 5 years ago, if you went to the CEO of any organization and said, okay, I'm gonna hold you accountable for security. Like, okay, IT guy, what's the spend plan for the security budget? It could be endless, and you'd have no good security. We had FISMA. What a waste of energy. Checklists, going through things. What relationship were those checklists to actual security? We had to shift the move to monitoring and actual outcomes, because then we could start getting people to be smarter about how we're going to manage. So my sense of it is, we did the following in healthcare. Under the HITECH Act, it is now a financial burden for a health system for data breach. They have to report, and they're on the hook. That's big teeth. That's more teeth than on the retail sector. So it should have led to more investments in cybersecurity. And even still, we had breaches on basic things like password management and don't have an admin get access to the whole kit and caboodle. And they just didn't get their acts right. But you better believe with ransomware, they're on this thing like whatever. So now they're all saying, hey, I want to plan for that. So we got to do a better job of making it easier to get to best practice. And that's like, the industry has to do better. But I would say on this issue, the digital identity is a common challenge. If you set up a bank account, if you set up a health record bank account, like Bill's describing, or my student records in my K-12 or my college degree, these accounts, standard usernames and passwords, can't cut it in today's environment, but what else? And I think we have to collectively sort through those things. I do want NSTIC to work. It hasn't quite lived up to all its potential, but it's getting better. But we got to have more. And I think a role for Congress could be, what is sufficient identity so that when the consumer says, I want Dr. Yasnoff to be my designated primary care doctor to access all my stuff, give him or her the keys to my account. Well, how do I assert that, and what's good enough? They could say, we want answers to that in 12 months and demand that there be, I don't know, I'm making it up here. So Congress can do something on the identity verification issue. They can be doing something on giving the whole record set, not just a subset, and they can do it around this delegation piece so that, I'm making this up here, but I think these are all things that can be done.
I think one thing that clearly needs to be done, and we need to get to the questions, one thing that clearly needs to be done is there needs to be and this is being done more and more, is there needs to be very aggressive enforcement of HIPAA in terms of organizations that refuse to release information when
Amen.
patients request it.
Amen.
And I will say OCR is doing a better job.
Let's open it up.
I'm Bob Gelman. I'm a privacy.
We'll bring the mic to you.
I'm Bob Gelman. I'm a privacy consultant. I've been involved in privacy.
It's not on.
For 40,
There it is. It's on.
it's on.
Yep.
For 40 years. I don't think the discussion has paid enough attention to the privacy and economic consequences of what you propose. I don't take major issue with the broad goals, but HIPAA applies to records held by healthcare providers and insurers. If you give information to anybody else, it has no legal protection. If you give it to a patient, it has no legal protection in the patient's hand. If the patient gives it to an app, there is no legal protection for that.
Unless it's on HealthKit.
Maybe. That's not necessarily legal.
It is, because under the FTC's enforcement, if they sign on to the
FTC enforcement is worthless.
Oh.
You're not going to go protect individual consumers.
Okay.
And it's not much. It may be something, but it's not. It's not as good as the protections in HIPAA, which aren't as good to begin with. Nevertheless, that's a major problem in that, a patient loads a flashlight app on their phone, and they've given consent for the flashlight app to get access to their entire medical record, in which case the records all go to marketers and to pharma, and patients get marketed for high-priced patent-protected drugs, and healthcare costs go up. They don't go down as a result of that.
Right.
That's one consequence. Patients aren't capable of providing their own privacy policies. They need a legal structure for that. And part of the healthcare environment that isn't protected by HIPAA needs protections if you're going to do it.
Sounds like you like the Consumer Privacy Bill of Rights that Daniel was having some
I will
quibbles
give-
with.
So why don't we stop there and get a reaction from the panel to that?
So Bob, I certainly agree with you, but I'm opposed to extending HIPAA to this domain because HIPAA has the TPO exceptions, treatment, payment, and operations, that essentially give the holder of the information the right to decide whether the exceptions apply. I think the right way to protect healthcare information is to tie it always to patient consent, as it was in the original HIPAA regulation before it was modified in 2002. I think patients should ultimately be the owner of their data. No one should be allowed to use patient data without consent. The provider should be entitled to a copy of the data, but as in their entitlement to a copy, that should not give them the right to share the data with anybody. And you always should have to go back to the patient for that. I do think, though, and this is, and I'd be interested in your view on this, I think that in the health record bank environment, the Electronic Communications Privacy Act applies. And so, which, as you know, says that when you have an electronic service holding your data, no information can be shared with any private party without the consent of the subscriber. Now, there are some problems in there with the government and so on.
Can I respond to that?
Yeah.
Well, why don't we had a number of hands, so let's get through a few more.
I'd love to talk to you about this.
Yeah, on the.
Hi, my name is Rita Dripstick. I have a couple questions actually, and part of it relates to some of the suggestions that Dr. Yasnov raised around the notion of having complete medical records and with the patient controlling a lot of that. And I'm wondering if there's a gap in terms of even how this program is titled in terms of the future of health data sharing, which is followed by giving consumers private and portable access to their own medical record. But this doesn't say anything specifically about patients sharing that record or contributing to it as through patient-generated health data. So I think there's a bit of a gap there in terms of a lot of what's been discussed today in this session. And the other thing is that really, to your point, having complete medical records, how can it really be complete when anyone can't even edit misinformation that may be in there, or better yet, because this is actually part of the current HIPAA privacy law, they don't always get their amendments acknowledged and as to be integrated within their own medical records if the doctor disagrees with what they presented. That's one question. My second question, which maybe Anish would be have special insight into, given that your work with the government, is where do you see gaps with the current interoperability roadmap with all the things that you've been discussing today? So I'll just leave it at that. I have more, but I know that those two.
Can I address the first one?
Yes.
So, in terms of patient-generated health data, actually one of the big advantages of health record banks is it provides a natural place for patients to send and store and share, if they wish, their patient-generated data. And actually, if you think about it, there's important health data that really needs to, is kind of intermediate. So for example, if I get my entire genome sequence and I bring that information to my internist and ask him to put it on my electronic record, he's not going to do that because he doesn't have room and he doesn't know what to do with it. And so mostly my genetic information is information that I would like to store in my health record bank account and control who gets it. And of course, the meaning of that information is going to change over time as we know more about the genome. In terms of editing information, I think in a health record bank account that information needs to be labeled as to source. And so if information was deposited by a lab, it's labeled as this came from the lab. There are disagreements even within the health record banking community as to whether patients should be allowed to edit that information or not. I personally think they shouldn't be allowed to edit it, but what they could do is not share it if it's wrong. But if it was to be edited by a patient, then the information would say this was generated by the patient.
Absolutely. So,
and so
otherwise
the information has no integrity, and no physician will be interested in using it. But the argument that information from patients, is not useful is wrong because, of course, much of medical care depends on what patients say and the answers to questions that providers have. And so, but it's very important that it be labeled properly. I just want to say one more thing about patient control. To me, the importance of patient control over your own information, where you don't allow anyone to have access to it or share it without your consent, is how can you explain the alternative? In other words, essentially, if the patient doesn't control this decision about who shares their information, essentially what you're saying to the patient is, look, I know more about this than you, and so trust me, I'm going to act in your interest in terms of who I share your information with, and I'm not going to get your consent. Well, that just doesn't make sense at all. That doesn't promote trust. If someone says that to me, they say, well, trust me, I'm going to do things, but I'm not going to tell you, I'm not going to get your consent. That makes me not trust them. And so I think ultimately patients have to have control over this. I think there is a role for default permissions, advice, and so on and so forth. And I think the problem here is not that patients are going to withhold information. Patients want all their providers pretty much to have all their information, but they don't want marketers, insurance companies, pharma, even researchers necessarily to have their information. In fact, when the IOM did a survey on information, people's willingness to give their medical information for research, 1% of consumers said they're willing to have their information used for research without their consent. Over 80% said they were willing to do it with their consent. Basically, the message is, just ask me and I'll be happy to give the information, but don't take it without asking me.
But that's the entire reason why your consumer mediated model is the right architecture, because you can digitally consent. If I can consent my Apple TV to connect to my Netflix account with the ease of a click, I should be able to consent that my medical records be deposited in the bank, shared with the ACO, to my Walgreens app, my whatever. And I think the technical means by which that is done, and on the internet today we use OAuth 2 to facilitate that kind of authorization across disparate systems, and we've applied that in the Argonaut project as the common standard. I will make this observation on the interoperability roadmap. There's absolutely nothing wrong with the roadmap. The roadmap is lovely. I mean, it's a wonderful document, it's thoughtful, it's had good input, multi-stakeholder. The rubber meets the road, not in the roadmap, but in the execution on each step. And so, for example, CMS's decision to allow consumers to take their Medicare files and connect them to an app of their choice voluntarily, not under a meaningful use rule, but under an awesome CMS, Niall Brennan is amazing rule, then we have an example where the feds are doing something to sort of eat the dog food, as you could say. So Blue Button on Fire is something I'm very excited about. It might actually be the first health entity in a production environment live on an open standard like Fire for this exact purpose. I authorize said app to pull my Medicare claims history, and off we go. So, roadmaps, lovely. Implementation, feedback loops. This is rough consensus, running code, feedback loops. That's the work of agile, kind of this model of the internet that we so embrace, this health internet idea.
Can I make one quick comment on interoperability? I think interoperability is a step on the way to getting to an ecosystem that makes sense. It's not the goal, and I think there's been way too much focus on that.
Thank you.
Right, cultural change being more important.
We need to think about the goal. It's just one step.
Thank you very much. Very, very helpful. I learned a lot. My name is John Graham from the Health Technology Forum, DC. My question is about claims versus clinical, especially data, especially if we're looking at Dr. Smith, now looking at a patient's lifetime record, and he's never seen the patient before, a bunch of information from a bunch of other doctors he doesn't know. And I was thinking about the metaphors you both used, airplane. I mean, an airplane is maintained based on thousands of hours in the air, not how much revenue was earned on its flights. And in energy, it's hard to cheat. It's a fee per kilowatt hour. But many will argue that claims versus reality, there's quite a gap there. So I wonder if I can get folks' comment on that.
Claims data is better than nothing, but in many cases, not a lot better than nothing. And you can't really manage patients clinically based on claims data. You have to have clinical data to do that. And so, again, the vision
that I'm putting forth at health record banks. I mean, it wouldn't hurt to have the claims data, for example, that is essential in terms of prescriptions that are actually filled as opposed to things that are prescribed and never filled. So that's important information. But you need to have the combined clinical records of patients in order to really be able to do better in terms of that.
Yeah, and just to add to that, the problems with the claims data being kind of corrupted by financial incentives are kind of going right into our clinical data records, right? Because there's all these incentives to for coding purposes. Medicare itself requires huge documentation. The doctors, I mean, hopefully not saying a big secret, they're just cutting and pasting, putting stuff into their document backup in order just to satisfy the requirement. It's basically fraud. I mean, like there's huge problems here. So we do have, this is just another layer of issues, but it does argue for like making sure that there is a place for where there is some purity in the purpose of that, which is actually between the doctor and the patient.
Well, what if we were to take this natural marriage of the two to the extreme? If you look at the next gen Medicare ACO program, the institutions take on a heck of a lot of risk and they're responsible for the outcome. My guess is a very natural conversation to be had is waive a bunch of these legacy requirements that were meant for program integrity and billing and documentation. When you visit a fee-for-value only clinic, like Rushika's clinic at Iora or others, they do not document the way fee-for-service doctors document. They just don't. They don't need to. So it is my view that in the extreme, fee-for-value will actually allow us to clean up a lot of this rigmarole. Now, I also believe you cannot be a learning health system without claims. Because if you wanted to test a hypothesis, Susie was enrolled into this clinical program, she had this encounter, the claims will give you the absolute truth that she got care in other places. Maybe it's not documented accurately, and there's some gray, but you at least know she went to the ER on this day, she had a home visit on that day, this thing happened on this day, so you can use that to help understand the story.
But if you had complete clinical records, you wouldn't need that
Yes,
necessarily.
but
although I'm not arguing against it.
I would only make the case that even the electronic medical record represents a minority of the claims data signal. Take Medicare patients. Home health patients are on Oasis. Skilled nursing facilities are on MDS. None of that stuff is in any format, in any standardized way for anything. So I get your point, but if you literally want it, and here's the proof in the pudding. CMS has celebrated the second year of demonstrating savings achieved in its ACO program. And if you survey the top performers, every one of them squeezed like a lemon, all the lemon juice you can out of the claims data. That was the only net new asset they had. They didn't have health record banks and all these other things. All they had was the claims, and the evidence is pretty clear. It helped them achieve success. So I think there's something there. We all wish it were better. We'd all get to a world where we only document what you need and it's all open and shared to the patient.
Great, well, thank you. I was just reflecting back on, I think we did an event on this paper 8 years ago. I think I opened with saying that my dog had a better electronic health record than I did. I don't think that's true today, so I think we have progress. So at least we have
Your car has a better record. Jiffy Lube has all my stuff, and there's longitudinal.
Those are better. So anyway, I think we could go on for a lot longer, but we're ending now. Thanks to everyone for being here today and your questions, and please join me in thanking them.
Thank you.
You should sit down. Good.